I'll be talking on dissect donor preparation and donor insertion. I have no financial interest in any of the products. Endothelial keratoplasty, like we all know, is a selective replacement of the dysfunctional endothelium with a healthy donor endothelium. And this would be the preferred treatment for any cornea that has a diseased endothelium and a relatively normal overlying corneal tissue. The prime indications, like we all know, are pseudophakic corneal edema, Fuchs endothelial dystrophy, a failed graft which can either be post-penetrating keratoplasty or post-Descemet stripping endothelial keratoplasty, aphakic corneal edema. Also, some other indications would be any long-standing endothelial dysfunction post-herpes virus infections, endothelial dysfunction post-bee sting injury, ICE syndromes, and of course in pediatric age group, the CHED. Lenticule preparation, it can either be manually done or with the use of automated machines from Moria or Gibor, and also, as we all know, femtosecond laser assisted lenticule preparation. Coming to the donor tissue selection, this is of prime importance in dissect. We prefer a 40-50-year-old tissue because this unfolds better. Also, it's important that there should be good or adequate scleral rim around 2 to 3 millimeters. This is important because when the tissue has an adequate scleral rim, we get a good fit into the anterior chamber. Also, endothelial cell count greater than 3,100 is desirable, but then it's good enough if it is greater than 2,100. And like we all know, in any corneal transplant, phakic tissue is always better, and particularly so in dissect. Manual dissection instruments, which the basic instruments needed are a pair of dissectors, artificial chamber, and of course guarded blades. Dissectors, I use the Catena dissector. DORC ones are also good but are expensive. I am aware that some Indian companies are also manufacture many of the dissectors. I have personally not used one. Artificial chamber, it can be either again from Baron, Catena, Coronet, which are the various companies. There's a need to use a preset guarded blade. Usually it is of 350 micron meters or 400 micron meter thickness. Diamond blade can be used. If not, then many Indian companies like Madhu Instruments and Appasamy also manufacture these kind of blades which can be used during the dissection. Trifines, I prefer using 8.5 millimeter trifines. Different surgeons again have different preferences. This is a small video of the manual dissection. Like we see, first I have done a surface debridement, then a lamellar dissector of 350 micron meter is done, and then this dissector from Catena is introduced into the bottom of the incision, and a very slow lamellar dissection needs to be done. It's important to follow the contour of the cornea during the dissection. And again, like we see, the left hand, my left hand is catching hold of the assembly here. And at every step, it's important to follow the contour of the cornea and be gentle and gentle during the dissection. This has to be achieved for the entire 360 degrees. And there are, in fact, surgeons also use two different dissectors for this kind of a dissection. One is a straight dissector, which is there, and then again a curved one. Like demonstrated in this video, using only a curved one, you can achieve a good lamellar dissection. However, practice needs to be done in the wet lab before proceeding to use these kind of eyes in the surgery. So the dissection is carried out and then it is completed in all the 360 degrees. Following this, it's important that while removing the donor button, we have to be careful that it has to be gentle, otherwise there would be caving in of the cornea, which would result in endothelial cell loss. This is the trifiniation which has been done, and then we can see a nice 8.5 millimeters lenticule, which has been achieved with the manual dissection. The tips for good manual dissection would be, like I mentioned, a good adequate scleral rim, a good seal of the tissue on the artificial anterior chamber. The pressure in anterior chamber should be moderately high. A new guarded blade is preferred for the initial incision, and we always ensure that the dissector is at the bottom of the incision, and please follow the contour of the cornea while dissecting. Like I mentioned, the automated keratomes, one is the Moria, which is available. The other one is the Gibor microkeratome. These are expensive instruments. This is a video demonstration of the Gibor SLC, courtesy Dr. Jeevan Titiyal. He had come to our hospital for a demonstration. This is a metallic artificial chamber which is being used. This thing here shows the tear meniscus so that the tissue is well centered. A 400 micron meter blade is used. The epithelium is debrided, and a slow, the surgeon checks the tautness of the globe, and then the dissection is carried out. The pass should typically last 10 to 12 seconds. A slow uniform pass is important to get a good uniform cut.